All right. Hi, everyone. This is Howard Mann. Welcome to the webinar this Thursday. I'm going to start off this week and show some cases. This case has a kind of an involved history, so let me just keep that aside for the moment. But I will tell you that at the time this CT was done, and the CT is going to jump a little bit, but the screen shouldn't jump around. She did have neck lymphadenopathy, and one of the nodes, I'm not sure which one, was biopsied and showed granulomas. So a presumptive diagnosis of possibly sarcoidosis was made, but of course it's unusual to have sarcoidosis present with enlarged neck nodes like this. So just keep that in the back of your mind for a moment, and then I'm going to go forward now in time to 2017 from February of 2016, and I will show you that she has opacities in her lungs over time that are small nodules. Some of them, as you'll see in a moment, have ground glass attenuating halos. Some of the nodules, like there in the left lower lobe, are pure ground glass attenuating, and they're variable in shape and size. And some of the opacities that are slightly larger are not discrete nodules, but much more ill-defined opacities, like this one in the lateral basal segment with a central solid portion and a halo of ground glass attenuation. So that is in January of 2017. I'm still withholding some information, but I'm going to show you going forward in time that these opacities wax and wane. And when they do come back, they come back and look pretty much the same. So you'll see here that some have disappeared, but others have appeared in different locations. So that actually shows substantial resolution of what was present in January. Then you go forward in time to, here is May. Oh, that was in May of 2017. So I'll go forward to July of this year. And again, I'll show you that opacities have gone, but new ones have appeared here in the superior segment of right lower lobe. Again, solid portions with halos of ground glass appear. And then the most recent that we have was one that I saw the other day. So this is from, and I don't need to show thin cuts, so this is from November. And you'll see that new foci of ground glass opacity, plus or minus more solid central portions, appear in different locations. Here's one in the right lower lobe. So when they do come back, they look pretty much the same. So it turns out here that the history is, here I'll go full screen, is that she does have a chromosomal abnormality. Pardon?
It was jumping a lot more when you
We're not in full screen.
Have it in full screen on the last CT.
I'm going to try to remember to go full screen. So you'll see here that she does have a chromosomal abnormality, and as far as I know, that does not connect up with what she has, which is CVID. So she has a history of repeated infections. She does have hypogammaglobulinemia, and you can see some of the workup for the globulins down there. So the findings are very consistent with what one might see with GL-ILD. So in granulomatous lymphocytic interstitial lung disease, one of course can have granulomas. So perhaps the sarcoidosis in the nodes was that phenomenon. And then the lymphocytic part of it can be follicular bronchiolitis. It could be areas of LIP, as well as pulmonary lymph node, pulmonary nodular hyperplasia, which perhaps this is. Those patients may also have foci of organizing pneumonia. But what's interesting about that is that this spontaneous waxing and waning phenomenon may certainly occur in CVID. And I think this is a particularly nice example of it. I don't have a biopsy of any of these because they do go away. She's been treated with low-dose prednisone and hydroxychloroquine right there. But I think putting the whole thing together, I think she does have a manifestation of GL-ILD with waxing and waning opacities over a long period of time now. And this is one of the nicest ones that I've seen. I presume what we're looking at on the CT, and it's just a presumption, is a form of nodular lymphoid hyperplasia, where there's a high concentration of lymphocytes and perhaps a little bit less in the periphery, giving those CT halo nodules. Travis, have you seen one looking like this? Because one can see all kinds of pulmonary opacities with GL-ILD if you're there.
Yeah, we've seen some that look like this. And sometimes on histology, you'll have more of like an LIP type pattern, and other patients will have more of a follicular bronchiolitis type pattern.
Yeah. Yeah. So she continues to be followed. No progressive lymph node enlargement is present anywhere else in her body to suggest the possibility of a lymphoma developing in her. Okay, let me go to the next case. And this is an instructive case that has to do with the evaluation of a pleural effusion. So I'm going to show you a series of images taken over a period of time from roughly April of this year going forward, and consider the case as being one of an idiopathic pleural effusion. The patient's presentation is not that of an acute respiratory illness or empyema. So I'll show you a CT of the chest. You can see the effusion there. Remember, it goes full screen. And you can see there's some pleural fluid down there and some pleural thickening. But I'm going to show you here something that I consider really significant anytime you're dealing with a pleural effusion of unknown etiology and it's not going away, and initial pleural tap and cytology does not reveal a diagnosis. And that is to view areas like this of pleural thickening involving paramediastinal pleural surfaces with considerable suspicion. So here's an example here where there is mild but lobulated pleural thickening. Here, medial to superior segment of left lower lobe. And as I scroll down, notice how lobulated and somewhat nodular the pleural membrane thickening is. Here's one area in the lower
Yeah, and
chest.
even laterally there too.
Yeah.
When you, yeah,
Yeah. Here is
yeah,
an
that's
area
a
of the chest
very
that
good
I think
example.
is easy to go by, but is pretty significant. And that's because this pleural disease right here that doesn't contain none in between it, but is pleural space abnormality, is easy to go by. And if you look up here and you see that abnormal opacity there, again, it's thick, it's lobulated. In relation to that pleural surface, view that with substantial suspicion. Of course, you know which way I'm going right here. I'll show you a PET CT to show that, and this is from 2 months later, that it's rather, in terms of FDG avidity, at an initial glance, not that dramatic, because usually with malignant mesothelioma, which this one is, the pleural membranes usually enhance substantially, or I should say, they're usually very FDG avid. And this one isn't that so much, but there is some certainly in relation to that pleural surface. And then just quickly go to July, and again, you'll see that pleural fluid remains, but this pathological thickening remains. So he had a TAP. I think they may have done a limited pleural biopsy, all of which revealed nothing, but the diagnosis was made at VATS. So when you see that kind of pleural thickening, hold your horses. Particularly, you can see here it's kind of progressive, involving the interlobar fissures. So this is mesothelioma. It did require a VATS biopsy to diagnose it. And there you can see a description of the pathological findings and the pathologist's description of it, as you can see there. All right. Let me me show you another one. This is a patient with a really bad actor, and I'm not sure what his symptoms were exactly, but I'll show you, going back to July, that an initial glance, if you just stop right there, you would think there's a bit of pleural disease. There's definitely some abnormality in the basal chest, but if one keeps on going, you'll see that it is in fact pretty large, and then potentially easy to go by if you're scrolling quickly and concentrating on pleural disease or pleural tumor is the rib destruction, which you can see there. So I'll show you the extent of it on an abdominal CT, and you'll see its relationship to diaphragm and how this tumor is really traversing the diaphragm into the subphrenic region and the associated bone destruction. So certainly one would think of a sarcoma. This one was ultimately called after a panel of different cell surface receptors, something they couldn't quite diagnose beyond a high-grade pleomorphic spindle cell tumor. A bunch of these things are negative, but it probably doesn't matter. This is just a really bad actor, and he's being treated for it. So a bad sarcoma in the basal chest. Now this is an interesting patient with findings on radiography and CT, as I'll show you in a moment, very typical of pulmonary hypertension. So the dominant findings here are the dilated pulmonary arteries, the enlargement of the heart. One does not see dilated pulmonary veins, so certainly consistent with pulmonary arterial hypertension. And I'll show you a couple images from the CT, which doesn't really add to the case, but certainly dilated pulmonary arteries. The main pulmonary artery, of course, is huge. I'm almost surprised that the right cardiac chambers are not bigger than they are, but certainly clinically she has pulmonary hypertension that's rather severe, and findings consistent with that. So certainly based on what we see in terms of imaging, and there's no evidence of embolism, this would be group 1. So group 1 includes the idiopathic, the heritable ones, among others. But the only potential clue to the diagnosis here is prior periods of methamphetamine abuse. So based on methamphetamine abuse in the past, this pulmonary hypertension was ascribed to methamphetamine abuse. So it's certainly one recognized cause of pulmonary arterial hypertension. And based on,
I would say that
it does carry that.
I would say that meth is.
Pardon, Travis?
I would say methamphetamine is probably the leading cause of pulmonary arterial hypertension that we see in San Francisco now. We see a lot of it.
Okay, I think we don't see it here in Utah. I think maybe this is the second one that I've seen. Typically when I see this, I usually diagnose, at least initially, of course, idiopathic pulmonary hypertension, or if the patient has a family history, one of the heritable causes of it. But yeah, we don't see that much here. But nothing about the imaging that leads one to the diagnosis. It's just a matter of getting additional information, right? Okay, let me show you an interesting case here.
Sorry. Yeah, I was muted. Yeah, it's indistinguishable from other causes.
Okay. So this patient presented with, at least initially, this radiograph. Clearly, the dominant findings are this opacity or the mass in the chest. I haven't shown you the lateral, but there's some pleural fluid. And I think the first time that I encountered this patient was in the context of reviewing a CT. So the CT I'm going to show you here, I'll bring up thin cuts, was done a short while thereafter, or was it on the same day? And I'll just quickly scroll through there just to give you a feel for the mass. One thing that caught my attention was the presence of interstitial edema in the right upper lobe in the form of peribronchial fluid cuffs and many septal lines, and then the focal opacity there as well, and pleural fluid. So initially I thought, okay, this is clearly a cancer, and thought of lymphangitic spread of tumor. I'll come back to that in a moment, but I want to show you the PET CT. And to my eye, and you'll see that this is a big tumor. Looking in the background of the right upper lobe, it really is very pink. And I thought for sure this is conclusive evidence of lymphangitic tumor spread, which it may well be. But there is another finding that complicated things when I began to look at the CT a little bit more, and that finding is more easily seen on the coronal. So let me bring that up. So two things to think of course, in this context is one, lymphangitic spread of tumor, and the other one is what is the state of pulmonary veins in the right upper lobe given the size of the mass. And sure enough, on the coronal particularly, you can see the vascular encasement involving portions of the pulmonary artery, but also substantially the right superior pulmonary vein. So now I don't know for sure. Perhaps it's both lymphangitic tumor spread. This is a small cell cancer. But another plausible explanation for the interstitial edema is tumor encasement and compression of the right superior pulmonary vein. So either way, the patient's of course going to be treated for the small cell cancer, but that's an interesting finding too. I don't know why there is so much FDG avidity there. I always assume that if you see that much, it's because there are lots of tumor cells there. But in this case, of course, I don't know for sure, but I was quite impressed by that appearance. So I don't know if anyone would strongly lean one way or the other, based on this kind of appearance to the right upper lobe. But
yeah, I think it's hard.
Towards lymphangitic tumor spread when I see that for sure, ordinarily.
Maybe since there's a little bit of metabolic activity there, that you more likely favor in lymphangitic spread of tumor, but I agree, it's hard to know.
It's hard to know. It could be both, of course. All right, so that I thought was really interesting. An interesting presentation of septal lines confined to the right upper lobe.
Right, and of course the problem with that too is when they respond to treatment, the vein's going to open back up, so it's going to decrease regardless of whether it was tumor or
one would think
asymmetric edema.
Yeah, unless of course, yeah, it's going to be hard to tell.
Okay.
All right.
Well, Howard, I was able to load a bunch because it looks like we've got a pretty small group today.
Great.
But I will take over and show at least a few cases here. So, do you see my screen?
Yep, good.
Okay. So I went through and pulled up a bunch of old cases, and I've got some new ones as well, and there will be a mix of pretty classic stuff and other things. And just looking at the radiograph here, I'll give everyone a second to look at it. Of course, you see there's a little bit of an abnormal convexity here at the right cardiophrenic angle. And when you look at the lateral view, I think you'd all agree that this is the posterior wall of the inferior vena cava, so right-sided structure. And then we see this extra lobule anterior to that. So it looks like it's localizing anteriorly on the lateral view. And the reason I show this case, it's not really much of a diagnostic dilemma, but you'll see that this is a multi-lobed fluid attenuation structure anteriorly here. And it was eventually excised. I don't know why they decided to take it out, but it was a pericardial cyst. And I think probably the explanation for why she presented, you can see there's a little bit of subtle pleural or pericardial thickening anteriorly. And there's also a little bit of atelectasis and probably a trace of fusion on this side. So the patient came in with chest pain symptoms. And so the best guess is that this became superinfected. It's not really hemorrhagic attenuation. But by the time they took it out, it was not actively inflamed or infected, but is a path-proven case of a pericardial cyst. in a good location.
Yeah.
And I think that, and you know, I know that all the books will say 3 or 4 millimeters for pericardial thickening, but I would argue that this is just looks like there's a little bit of inflammation surrounding it, a little bit of stranding in the anterior mediastinal fat at least, and maybe a little in the epicardial fat as well. And just like that case you were saying, you know, with the pleural thickening, that it just, even here, just looks like there's a little too much stuff medially. So I think it's more of a focal inflammation there. But path-proven pericardial cyst, and they did an MR, which isn't, you know, isn't really worth showing. I'll include it though. This one is kind of interesting, Howard. I think you'll like this. So this is a more recent radiograph, and you see this lobulated thing in the left upper hemithorax. And we can see that there's a fairly well defined border medially. And of course, as we look laterally, you'll see that there's no lateral border. So the so-called incomplete border sign, telling us that this is probably either abutting or arising from the pleura, or maybe the extrapleural space. And in cases like this, always want to look at the bones and make sure there's no underlying destruction, or that it's arising from the bones, like a plasmacytoma or something.
Yeah.
But I'll show you, this was 10 years before that, this scout, and you can see there's something there. And I'll show you what the CT in 2005 looked like. It's kind of interesting. So you can see that this is a huge fatty lesion. And there's a couple little lines through it, probably just vessels. And so at the time it was just, you know, chalked up to being a benign extrapleural, pleural or extrapleural lipoma. And I actually don't know. I wonder if it's actually extrapleural, because there's a little bit more fat here in the chest wall. And I don't know if some of this could be intercostal muscle that's just stretched internally. But if you compare that, they actually repeated a CT and ended up getting a PET CT. As you can see now, it's gotten substantially larger. And I think here on this one, would you agree, Howard? It looks like it's actually coming from it's just growing in from the extrapleural space, like from the chest wall.
Sure does, I think, yeah.
Yeah. So they did the PET just to see if there's any metabolic activity. There wasn't. And I'll show you here. I don't know, but you can see it's a photopenic area right in here.
Oh, yeah.
And so they didn't take it out. And I don't know, maybe it could be a low-grade liposarcoma, but they're just continuing to watch it at this point. But it's really interesting, because I think it probably is extrapleural. It almost looks like there's, you know, like we see with Morgagni hernias, where you see the little vessels coming through almost like on a little stalk there.
Right.
But it would be interesting to have path on this. Of course, it could be a low-grade liposarcoma, I guess. I've never really seen one in this location, but yeah, but they have not taken it out yet, even though it's enlarging.
Yeah. Yeah, it seems to have pushed the intercostal muscle aside, or attenuated or stretched it, so that the intercostal muscle is not perceptible as such. It's just
right. It's like right there.
Yeah, exactly. Interesting.
So I thought that was a kind of interesting case, and it's a nice radiograph with the incomplete border sign on that radiograph.
Very nice.
Okay, then I'll give everyone a second to look at this. Howard, take a shot if you see the abnormality, and it's actually unrelated to the port that the patient has.
Yeah, there is a mediastinal lung interface that's convex rightward at the level of the azygos vein, but I think I can see the azygos vein through it and the ribs through it. So that convex mediastinal lung interface is.
How about on the lateral?
So when I look at the right and left pulmonary artery at the level of the hilum, and then my eye goes superior to where I'm looking for the left pulmonary artery, there's too much opacity there.
It's kind of ill-defined, but it's dense. And you're right, yeah. So there's something sitting in the middle mediastinum, and of course, the presence of the port catheter makes you think it's going to be metastatic disease, or something. You know, I don't remember what her actual history was, but as we go down, you'll see exactly right here. So it's middle mediastinum. The epicenter, I'd say, is in the middle mediastinum. Of course, if you go by Felson's, 1/3 of the vertebral body versus 2/3 posterior, clearly this is middle mediastinum. And this was one where thought maybe it was going to be a foregut duplication cyst. It's a little, let's see if we, let's see if I can get the tools up here to measure. You'll see the, it's pretty high attenuation. Doesn't mean it couldn't be a hemorrhagic cyst, but it's even pretty high for that. So of course, the other thing in the mediastinum would be some sort of lymph node or something associated with the esophagus. And they took this out, and this actually turned out to be,
or even a nerve-related lesion.
yep, true, yeah. And this turned out to be a leiomyoma, so of the esophagus, and so it was a submucosal mass. And I think when they did an EGD, they saw that there was something there, but it was not in the not in the lumen, but it was submucosal. So, but a good radiograph, good pickup there. And yeah, we don't see too many esophageal leiomyomas, but of course it's on the differential. And I have seen a submucosal schwannoma too, or neurofibroma, I can't remember, but it was a mucosal tumor associated with the esophagus. But that's what this was. And actually, now that I look at it, the esophagus has been displaced rightward right here. Wow. So it's actually, okay. I guess it's kind of pushed the esophagus around. You can see it right here. So this thing starts out on that side, but then kind of displaces the lumen more to the right. So that was one esophageal leiomyoma. And here we don't have a radiograph, but you'll see in this patient, they had a swallowing study done for some reason. I don't remember if it was dysphagia or what, but you can see there's what looks like an eccentric mass effect and compression of the esophagus. It doesn't look like a typical apple core lesion. And you can see this a little bit lower down the center of the shot, but it's near the level of the carina. And it came in around the same time. This is a little bit older patient, but you can see in him, there's a esophageal mass or a middle mediastinal lesion that is involving the esophagus, which otherwise I don't think I could be confident any which way in what this exactly is. But because this could still certainly be a primary esophageal, tumor or cancer, but this actually turned out to be another esophageal leiomyoma. So there was progressive dysphagia over years, and so this was another one. So two of them that came in around the same time. I don't know, Howard, do you have any clues for how you would say that, other than it's fairly uniform in attenuation?
Yeah, intimately associated with the esophagus, quite homogeneous in attenuation, very consistent with that. Yeah. Smooth margins, not infiltrative as such that one can discern.
Right. And occasionally we'll see dystrophic calcification in leiomyomas, but not in either of these. Okay, right. So those were a few old ones I pulled up. Let's see. I have to remember what this one is. Let's see. Oh yeah. So this is an interesting one. This is a patient who came in, and he has, I'll show you, when you look at his lungs, let's make sure to maximize here. You can see his lungs are just too busy. He's got lots and lots of tiny little 1 to 2 millimeter nodules. And I always find that in cases like this, it's always nice to pay particular attention to the fissures. And you can see there's a little bit of studying of the fissures on both sides. So, and along the minor fissure as well. So innumerable little nodules in a random distribution certainly, would fit with miliary description, either metastatic disease or some sort of disseminated infection. This guy does have a history of cancer, but his cancer is a superficial bladder cancer. And he has sure enough been treated with intravesicular BCG. And about a couple weeks before this study had a cystoscopy in addition to his BCG treatments, and was admitted with sepsis. He improved for a few days on antibacterials, vanc and meropenem or broad spectrum antibiotics, but then after they stopped those, he started to get worse again. They transferred him here, and that's when this whole history, the possibility of this being BCG was raised. So nothing in the imaging itself that tells you that's what it is, but other than they're just diffuse miliary nodules. And his PPD was negative. He didn't have, his workup for tuberculosis, his quantiferon was negative. And he was treated with 3-drug therapy and got better. But from my from my reading, because we've seen a couple cases of this, and it can cause sepsis and death in a minority of patients, but usually there's some antecedent intervention in the bladder as well. Like oftentimes there will be a cystoscopy or something that that in theory causes trauma to the bladder that allows introduction into the bloodstream. But he got better on his 3-drug therapy and was discharged recently. But I think this is confirmed case, of BCGiosis, even though they didn't do a biopsy. So
interesting.
It's been a while since we've seen one, but it's always important to remember in the setting of superficial bladder cancer, because of course BCG, intravesicular BCG, is a treatment for that. And so I like this discussion. This case report only has radiographs, which pretty much are not very contributory. But there's a little discussion here. We're just talking about the hematogenous introduction of BCG, and especially after traumatic catheterization or something that can disturb the integrity of the bladder. All right, let's see. Here's one patient that came into the emergency department, and this was last month. And I don't know, Howard, what's your take on the radiograph here?
Okay. I see opacity in the tracheobronchial angle that I'm going to ascribe to the azygos vein, but I'll keep that in mind a second. Yeah. I'm trying to decide whether the right hilum separate from that is abnormal, but I'm not sure. Yeah. I'm not sure though.
So yeah, and this is this is admittedly my least favorite finding on a radiograph, especially in a patient with chest pain, right? Because you have a little abnormal convexity, and I don't know how you approach these, but every time I see something like this, I usually, in that context, I don't know what to do. Is it just a tortuous aorta? Is there an aneurysm? Is there, could they have a dissection or something? Because I'm sure, we've shown cases where just how worthless the radiograph can be. But yeah, I don't know. This was not, nothing was called there, and I wouldn't say anything,
right.
Fault anyone, because I don't, it's hard to know if there's anything there. But they came back 2 days later with worsening chest pain, and now you can see that I think this is a good example in the non-con of course, high attenuation crescentic wall of the aorta. So this is an acute type A intramural hematoma. It's probably a little bit of blood tracking along the right coronary artery, and of course, now you can see that they have hemopericardium. So this is obviously leaking into the pericardial space somewhere. Don't really see much in terms of shared adventitial sheath hematoma. And actually, that reminds me, I think this was, the CTA was done prior or after. Yeah, this was actually I don't know why they did this, but there was a PE study that was done, I think first, but I think it may have been this one. Yeah, the PE study was done first, and you can see because the patient had recurrent chest pain. And just, I think this shows the value of the non-con too. Certainly there's a lot of stranding in the fat here, and there's high attenuation fluid. And we even get a little bit of smoke in the aorta, as you see here. And I think that she's probably got some early tamponade, at least from the hemopericardium. But of course, you can see there's a little eccentric wall thickening, but the value of the non-con is very useful in this case, as was seen on the subsequent repeat study. So they did all this before they transferred here. And then you can see on the follow-up study just done a few hours later, same thing. And there's, I don't know if this is the tiny little rent in the wall of the aorta.
Yeah, I'm always on the lookout for that to see if we can see.
Yeah, exactly.
Reach.
Yeah.
It can be very
so they went to the OR. They found a lot of blood. They said it was hematoma / thrombosed dissection. And I never, again, we've had these discussions on nomenclature all the time. I think in a case like this, it doesn't matter because it's type A and it needs to be treated surgically, especially when they have hemopericardium, indicative of leaking or rupture. So, but yeah, I don't know. What's your approach to the radiographs like this when a patient, especially in a patient that has chest pain or may have risk factors for an aneurysm?
Oh no, the aorta that's involved on that CT is buried in the mediastinum, and we can see the pathology there. So
yeah,
I don't think there's anything on this radiograph that hints towards the
No, and I'm saying
subsequently.
the actual pathology, but just in general, if you see a little convexity along the right, along the right heart border, that could be an aorta.
I
I
would
just never
never
know what
call
to do
that
with those.
prospectively, no.
Yeah. Okay. All right. Two more. Let's see. I need to remember which one this one is now. Let's see. I think this is let's see, is this an older one that I put up? Oh, yeah. This is a case that I actually just saw a follow up on today. I think it's pretty interesting, though. So, this is a lady who, at the end of 2016, presented outside hospital with right sided flank pain. They did a radiograph, which led to a CT. And I think you can see here that when we look at soft tissue windows, there's a peripheral area of consolidation. So, if you want to say just nodular consolidation, mass-like consolidation, whatever. But I think the interesting finding too, there's a subtle little lower attenuation center here. Of course, with fever, you always think about pneumonia. She didn't have any, there's a little bit of motion here. I think there's a couple little nodules, but I didn't see a big PE to explain this being an infarct. And it looks like it's enhancing more anyway. I think what's interesting is just the surrounding ground glass opacity and the septal thickening too. She didn't have any hemoptysis. So I think this may just all be an inflammation, maybe a little bit of asymmetric edema related to this. But she was treated for presumptive pneumonia since she had cough and fever and really nothing else. Then she had a radiograph a couple or month later, and you can see now she just has a little residual nodular area of consolidation posteriorly there. Then she comes back a few months later and she has fever, still ongoing systemic symptoms, ends up with headache, ends up with just diffuse body aches. And you can see here that she has, this residual nodule in that area that was necrotic and a few little satellite nodules in the same lobe. And then she saw infectious disease. They did titers and everything. And she ended up having coccidioidomycosis and disseminated cocci. And around the time of the original infection, they had been building a new house. And so she had been exposed to a lot of dust and whatever matter outside. But that was probably her exposure. And so this was 2017, so a few months after, and I think that radiograph looked pretty similar. And then this is today when she came back in. And there's really, and we see this a lot now, that it's identical after a year and a half, even the little satellite nodules. And what's unfortunate is she had stopped her antifungal therapy, I guess AMA, a few months later, and ended up with severe meningitis, and that's been recurrent since then. So she's on lifetime antifungal therapy now, and they just did this because I think she's been waxing and waning symptomatically, but her lungs look entirely unchanged. But this is kind of, I think, acute cocci that then just ended up with this coccidioidoma and then a few little punctate nodules adjacent to it. And maybe there's the tiniest bit of laminar calcification developing in there. I don't know. We'll see how it evolves. But I think there's a little bit of concentric calcification. So, yeah, well, unfortunately, we see a lot of these cocci cases. So, but I think I've got, let's see, one more. This is an interesting one. I know Seth's not on here. I think that it's a good cardiac case, though. This is a patient who is young. You can see they're 26 years old and came in with worsening dyspnea, chest pain, troponin leak, and you can see they have what looks like edema. They have effusions, probably some underlying left lower lobe collapse as a result, and then just fairly symmetric hazy opacities, all edema. And this was a couple days later. They tuned him up. He had a troponin leak, and I think he even had a pericardial drain, because you can see looks like maybe a little bit of pneumopericardium there. But they eventually did an MR, as they always do in these patients, looking for just the cause. He had a cath at an outside hospital that was negative. And you'll see that his function here is 35, 40%. So it had already gotten a little bit better. And you can see that there's a little bit of heterogeneous signal in these T2 weighted steady state free precession cinae. then let me go to the, and then so the short axis cineas are done after GAD has been administered and before it's accumulated, or before we do the late gadolinium enhancement. So it's probably a couple of minutes after. And what's really impressive is just the amount of increased signal in a subepicardial distribution. So of course, with subepicardial, even extending into the septum, you think first and foremost about a myocarditis in a young patient in particular. Sarcoid, other non-ischemic diseases can do it as well. He didn't have any lymphadenopathy or anything else going for sarcoid. But I include this just because it's one of the best, if not the best example of delayed enhancement I've ever seen in a patient with myocarditis. And you can see, I mean, there's no doubt, and I don't know if I've ever seen myocarditis that was this extensive, even into the septum, but just maybe a little bit of transmural at the apex, but predominantly subepicardial in the inferolateral walls and in the septum as well. So this is, I'll just show this one just because sometimes we don't show the common stuff, but even though this is one of the more common things we see, it's the most impressive case of it that I've seen in a long time, if not ever, with this amount of enhancement. And there's some cases where you may see like giant cell myocarditis is a subset that may present with a more florid course. His function was returning, and so hopefully he'll have a reasonable prognosis. But just severe subepicardial.
Right?
What?
We typically ascribe it to a virus, right? Viral myocarditis.
Yeah, and I think if I remember, I think there was something. Yeah, so he that's right. He had flu-like symptoms, and then he's type 1 diabetic who ended up in diabetic ketoacidosis. And so it's probably that he had a viral infection that precipitated that. So there was some history of an MI at an earlier age, and they were unsure if it was myocarditis, and that's why he had the cath, and then that's why they went to MR. But this would not be an ischemic path.
I like the description, crazy. That is pretty.
All right. Well, that is. Oh yeah. So that's the last one I have. I think it's just the two of us for today, right?
Yeah. No, that was great. Yeah, it's just the two of us today. So yeah, thanks for showing.
Okay. Well. Yeah. So you too. So everybody. Oh, let's see. Somebody just chatted. Oh, Nelly was just saying thanks. So, all right, cool. Sure. Well, we'll I guess see each other next week then.
Great. Thanks, everyone. Thanks, Travis.
All right. And you recorded, right, Howard?
Yep.
So
I've got it.
Okay, great. All right. Talk to you later.
Okay. You too. Bye-bye, everyone.